The public option. Since the Affordable Care Act was passed in 2010, 18 million Americans gained new access to health insurance. Most of this increase came with expansion of Medicaid programs, even though a little less than half of the states did not accept it. But by 2019, over 26 million Americans remain uninsured, and an equal number underinsured. That means that their deductibles and copays were unaffordable, so they didn't go in for care. As a result, 1 in 4 Americans went without needed health care because of cost. In particular, communities of color remained more likely to be uninsured compared to whites. Coverage affordability remains a significant barrier to access for both insured and uninsured. In 2020, 7.7 million jobs were lost because of the pandemic. As a result, 14.6 million employees and their dependents lost their health insurance. That's 1 in 25 Americans. And that happened in a time of a pandemic when they needed access to health care the most. So that was one problem. Another problem is significant premium fluctuations, always going up, of course, and areas where private insurance companies were unwilling to offer plans. For example, rural counties. So there was no subsidized ACA marketplace plan in those areas. So because of these multiple problems, a lot of policy people have turned to the public option as a potential tool to promote stability and affordability in the individual insurance market. What is it? A public option. It is typically defined as a new coverage option that leverages government bargaining power to offer more affordable coverage plan for individuals and businesses. Since 2017, nearly a dozen states have considered or passed legislation to implement state-based public option program. In response to strong support from the American public, candidates for public office and elected officials across the country have backed the public option as a coverage affordability solution. Efforts to promote a public option at the federal level were bolstered by Joe Biden, who campaigned on a federal plan based on a Medicare program that would be offered on the marketplace. Presidential primary candidate Pete Buttigieg used the phrase Medicare for those who want it. It's a very similar concept. President Biden on March 11th signed the COVID relief package that makes federal premium subsidies for Affordable Care Act policies more generous and eliminates the maximum income cap for 2 years. Enrollees will pay no more than 8.5% of their income towards coverage. That's down from nearly 10% now or before that. Also, those earning more than the current cap of 400% of the federal poverty level, that is about $51,000 for an individual and $104,000 for a family of 4 in 2021, they will become eligible for help. In addition, the bills will bolster subsidies for lower income enrollees, eliminating their premiums completely for 2 years, and will do the same for those collecting unemployment benefits in 2021. The legislation also provides full premium subsidy for laid off workers who want to remain on their employer health insurance plans through COBRA. Just in a comment, yes, COBRA is essentially unaffordable. It kind of you can tell that by the name. The assistance runs out from April through September of this year. So what happens in September? Also, the package seeks to entice states that have yet to expand Medicaid to low-income adults and do so by boosting their federal Medicaid matching funds by 5 percentage points for 2 years. So all that's going to help a lot of people. The Biden administration may support state innovation to create new state-based coverage opportunities, even as major federal legislation is unlikely under our divided Congress. The appointment of Xavier Becerra to lead the Department of Health and Human Services is likely to allow this innovation. He is known as a single payer supporter, but in order to be appointed, he had to say he would not actively pursue single payer. While not impossible, the size and scope of a federal public option initiative is unlikely to pass in the Senate. As a result, policy activity on public option will continue to be concentrated at the state level. Without a federal public option, states will continue to consider whether a public option is an effective tool for meeting their coverage goals. Models include state contracted public-private partnerships, state-sponsored health insurance product administered through a third party, like self-insured companies do, or offering currently ineligible individuals the opportunity to buy into an existing public program. That's the Medicaid lookalike program, or for state employees like OEB and PEB. Evaluation of these models will be unique to each state and is anchored in the problem. Anchored in the problem is, what is the state trying to solve? For which populations? Is it the uninsured, the underinsured, or for the unsubsidized? In Oregon, the Manhattan Health, it's a professional think tank, at the request of the Oregon legislature, produced a study that considers the plan for a Medicaid buy-in program or public option. The study evaluates 3 proposed delivery models: the coordinated care organization led model, which the state utilizes the existing Medicaid network. That's one. A carrier-led model, which would be a private insurance model, and a state-led model in partnership with a third-party administrator. So in that case, just like Medicare sometimes contracts with a private insurance company like Aetna to do the paperwork, but Aetna does not take the risk. So the state holds the risk as the insurer, but uses the third-party administrator for processing claims. The study also included analysis of CCO-led model targeted to the undocumented and other excluded populations with state subsidies to ensure affordability. The study will be used to inform policy decisions and is being used during this session. And the bill is HB 2010. It is facing a public hearing in the House Healthcare Committee on Thursday, April 1st. You are all invited to attend. You can go to the OLIS, OregonLegislature.org, and if you just use your URL box, all you have to do is type in OLIS, and usually the rest comes in. And you can stay on top of this bill and offer your thoughts. Now we're into the debate section here. How many people would this public option help? Well, my perspective is that it would be a relatively small number of people. It would have limited bargaining power. It's likely that many of the sickest of Oregon's uninsured would join a public option plan because they have a hard time getting private insurance to cover what they need. And that would make a high risk pool. In a high risk pool, this dynamic drives public option prices higher. Health insurance plans will always be unaffordable unless a healthy patient pool balances the sickest. So what we would have here is a plan that is competing with private insurances, which are superb at avoiding risk. They know how to do that. But the public plan would be egalitarian and would not be competing to avoid risk. Therefore, it would accumulate the sickest and the most costly patients. In contrast to this would be universal coverage, which is not the topic of tonight's talk, but universal coverage would put everyone in a single large risk pool and would give the state the bargaining power it would need to achieve cost control. Oregon would negotiate global budgets with hospitals, drug prices, fair fee schedules with providers, and there would be streamlining of the processing of claims. So with that kind of simplified system, providers would face just one set of billing rules and processes, greatly reducing their operating costs. Having everyone in the system limits opportunities for unscrupulous providers to exploit desperate patients. Would a public option improve efficiency or reduce waste? No. Would it be affordable to those in the greatest need? At least three major reports estimate that 30 to 35% of America's $3 trillion healthcare bill is not spent on effective care. None of this waste disappears by adding one more insurance quote option. Without transformative change, some hospitals will continue to employ one insurance related clerk for every bed. In in Canada, it's one for every 8 beds. Here we have one for every bed. Physicians will continue to spend time and money fighting insurance company barriers, negotiating multiple different plan coverage options, pharmacy formulas and restrictions, and dealing with duplicative documentation efforts. Patients will continue to negotiate and hassle the annual enrollment time with its array of options and guesswork about what plan will meet their future healthcare needs. How can they really know that? Would it be affordable to those in greatest need? I think we just talked about that. Would it mitigate the problems of employer-based healthcare insurance system? Notably, how many people lost their jobs last year? And even in normal years, lose their jobs or change insurance and then have to change their providers or their medications? No, a public option would not mitigate these employer-based insurance problems. What would it help to have those who already have insurance? No, those people still have high deductibles. They would still be stuck in networks that restrict their choice of doctors, still be forced to be on constant guard for surprise medical bills and charges. No, it would not help that problem. I think we just talked about what a better solution is, and I yield the floor to Karen.
Okay. Mike has the technical expertise that I don't have, but now is my little chance to rebut. You're just going to have to look at my face, and that's it. No fancy slides. The public option is and can be a viable alternative to universal single-payer healthcare, which I don't think any of us are going to see in our lifetimes. I've heard it said that politics is the art of the possible. And I think it's time to look at what could be possible, and the public option is something that could be possible, and it could provide help to millions of people in the country and thousands of people in Oregon. About 6% of our population in Oregon is uninsured. That's about 250,000 people that have no insurance. And as Mike said, there are more that are underinsured. The Oregon Legislature House Healthcare Committee will be having a hearing and work session on HB 2010. And I think it's important to consider what this bill does. It's quite specific, and I think it will help a significant number of people in the state. It's a bill that would create a state plan based upon the individual's choice of a silver or gold marketplace plan. The difference between a silver plan and a gold plan is that a silver plan has lower premiums but higher deductible costs than a gold plan does. And I don't know if any of you have really been on the marketplace, but they rate the plans bronze, silver, gold, platinum based upon the combination of costs that a person can choose from. So they're very standardized plans, and all of the plans have 10 basic elements of coverage, so that there's comparability, and it covers really the coverage is quite complete in those plans. The state's goal in doing this is to, number one, provide the residents of the state with the opportunity to enroll in a plan, and for people who have employer coverage that only covers the employee, to have a source of insurance that's affordable for their dependents. And also to provide employers with the opportunity to enroll their employees in this plan as an alternative to the private insurance market, which someone was talking about the horrific costs for small businesses. And I know my business has really experienced those high premiums that kept going up uncontrollably. So how can this plan do that? Well, a couple of ways. First of all, they would reimburse providers at Medicare rates. So that is right away a cap. Secondly, the bill requires all providers who participate in either Medicaid, the Oregon Public Employees Retirement Plan, or the Education Benefit Plan to accept patients who would be on the public option plan. So there would be a wide range of providers to choose from. You wouldn't be forced into a small network. And I think because this plan, the concept is to allow employers to enroll employees, you're mitigating the problem of adverse selection and only having the sickest people who can't find insurance anywhere else come into the public option plan. If the plan is adopted, the state will sell it, have it sold on the marketplace. So insurance agencies would be involved in this purchase process. But the state is also asking that the Department of Commerce look into reestablishing the state's own marketplace platform for this plan. And what that would do is save the state cost. When you sign up for an ACA plan in Oregon, the sign up mechanism is on the federal government, and the feds charge the state a percentage of the insurance dollars for running the platform for the state, and also set parameters so that the state can't have a more expansive registration period, for instance. So Oregon would like to have their own platform. Try it again. I have to say they did fail and did not have a workable platform when they did it in 2014. But they would save money by having their own platform and also have more flexibility in the enrollment process. And the plan also is saying that it would be structured in a way so that the people who enroll in this plan would get all the benefits of the private plans in terms of subsidies for the premiums that they pay based on income, so that the Biden administration inroads into the costliness of plans would be taken care of. And the best thing about this, if passed by the legislature this session, is that the state would have people enrolled in this plan in 2022. And that's just around the corner. So it wouldn't take a long time to have this up and running, because the backbone of it is the already existing silver and gold plan platforms. So enough of that. On the federal level, it's still very open-ended and vague, and I agree with Mike that under the current political environment, public option is going to be seriously considered for a while, and that the best hope of getting healthcare reform is on the state level. And I think a very good step in the right direction would be the public option that's being proposed in Oregon, and it's been sponsored by Representative Salinas and Senator Beyer. It's got some bipartisan support, but we'll see what happens in the hearing on Thursday. So that's, I think, what all I wanted to say about the public option, but it's something that's doable. And if people are able to take part in it, I think it will help them reduce any questions that they have about the state being able to successfully run an insurance plan, it can be a ramp into it and can further be expanded to consolidate with our other plans, um, such as Medicare, such as the public employee plans for both teachers and non-teachers. So what we'd like to do now is hear your questions and comments and thoughts about where we might go and how we might get there. Cynthia.
I just want to know, so Oregon is doing this. Are there any other states that are farther along in this kind of health coverage, and what's their experience? Are you sort of being able to learn from some of the other states, or is this just really innovative for Oregon?
Mike, go ahead.
Thanks for asking that particular question. The only state that's implemented something like a public option is Washington. So beginning in 2021, there is an open enrollment. During open enrollment, they have an option to enroll in Cascade Care, the nation's first state public option plan. But they don't have experience to tell us yet how it's going to work. Premiums, let's see, the provider reimbursement cap will be 160% of Medicare rates. So that should appeal to providers. Providers, as you may know, some are accepting no more Medicare patients because Medicare reimbursement is lower than commercial. But 160% may make that possible. But in order to get to that level of payment, the premiums may be unaffordable, even by being lower than commercial. So we'll see. So that's one. Other states have passed it in the legislature, but governors have vetoed them.
Someone in the introduction section asked about the report that Oregon had done. And I think you were referring to the RAND report, which was released in 2017, if I remember correctly. Oregon spent $400,000 to have the RAND Corporation analyze the cost of the present system, a public option, another kind of hybrid system, and a single payer. And the conclusion of the report was that it would cost us no more to go to a single payer system than we're presently spending on healthcare, and everyone would be covered. The RAND report is being considered by the Senate Bill 770 task force, which is operating at this time. That task force is charged with making a recommendation or a report to the legislature about how do we get to single payer for Oregon and what should that plan look like. So it's not been shelved, it's being considered, but the 770 task force is still doing the work. They're meeting monthly. And again, at that OLAS site that Mike talked about, you are able to listen to all their meetings. The next meeting is, let's see, in April. I'm not sure of the date. I think I do have it on the calendar here. They'll be meeting on April 29th, which is a Thursday at 1 o'clock. So it remains to be seen what they're going to come up with. So far, they're discussing a lot of things, but they haven't made many decisions.
Universal healthcare and all the whole healthcare system has been talked about a long time, especially during the last presidential campaign.
Mhm.
And, in particular, I guess Bernie Sanders and Elizabeth Warren. And, we make no headway. And what I want to know is, because this is my guess, are the biggest barriers to this that there are the insurance companies, the pharmaceutical companies, the hospitals, and the doctors that don't want it because they won't make as much money? I mean, that's what sticks in my head. Is that what our problem is?
I think that's a part of the problem. I'd also add though the cultural climate and the resistance that someone mentioned in the introductory comments. But David, are you raising your hand?
Yeah, it was a reflexive thing when Cynthia mentioned the doctors being against it. The truth is that doctors are now on our side. PNHP did a survey several years ago using the American Medical Association's list of doctors and asked the question, are you ready for single payer? And 60% of physicians said yes. It depended a lot on what specialty the doctors were in. The doctors who were most in favor of single payer were the psychiatrists. The ones most opposed were the radiologists, but we have in our midst one radiologist who is all for it.
Mike, yeah.
I just wanted to add to David's comment. The American Medical Association has been the biggest obstacle since Teddy Roosevelt against universal health care. And Truman came close, but AMA rose up with the help of Ronald Reagan coffee hour records to squelch that. But things are changing with young people coming into the AMA. So in 2019 AMA convention, they did one significant thing. They dropped out of the Partnership for American Healthcare, which is a cabal of insurance companies, pharmaceutical, medical device companies opposed to universal healthcare. The AMA dropped out of that, which is a big step, and they came within 1% vote of dropping their opposition to single payer. So that was in 2019. So I think we're headed the right way.
Shelley and then Kate. Oh, Shelley, you're muted.
So Mike, why do you feel like a public option passed in the interim before we get our plan for universal care? Why do you feel it stands in the way?
So my understanding is that it would affect at most 28,000 people. That's less than 1% of the population. It's going to take a certain amount of effort, research by the Oregon Health Authority to make it happen. Those people, those resources are desperately needed by the task force to help us figure out how to create a single payer system. Those are two things that come to mind, the very few people that it would affect. And then addressing Karen's point about, well, those people now with this employer involvement, which I was unaware of, would not be facing the same adverse selection, that is cherry picking, lemon dropping, that the rest of the population faces. But if that's true for only that 1%. It still leaves the other 99% of us still open to adverse selection by the highly skilled actuaries in the insurance companies.
I can't resist not coming back a little bit on that. And I think the estimate of how many people would be attracted to the plan is really quite speculative in the Minot report, which was done before COVID. And I think that has been a big game changer for people, that we're in a different territory now. In Oregon, the latest statistic I saw is that there are 141,089 people in the ACA exchange plans for 2021. And I think many of these people with an open enrollment period might be interested in switching to a less expensive state-sponsored plan that provides the same benefits of the silver or the gold plan, depending upon their choice of the premium and deductible levels. And those plans are more affordable with the federal subsidies that have now been put in place, and I think are not going to be just a temporary feature. And I do believe that there is a possibility that this would be a glide path and give people confidence about the ability of a state to successfully run a plan. And I don't think it would take that much time away from OHA. Originally, I thought it would, quite frankly, but since they have tagged this to a silver or a gold plan, those plans exist. Everybody knows what those benefit levels are, what the coverage is going to be. So there isn't much creativity that's needed there. It's basically, and because it's being sold on the marketplace through the existing agents, the only thing that will take staffing time is to look at the institution of a new state platform. So I don't think it'll be a significant deterrent from the progress of the task force or Oregon's move towards universal health care.
Cynthia's had her hand up for quite a while.
Or you had Kate.
Kate,
Yeah.
yeah, sorry.
This is going a slightly different tack, but how much of the controlling of healthcare going on is going to be the cost of medical schools and doctors coming in with huge debts? If
Mike,
they-
you want to respond to that as a doctor?
Well, I don't know what percentage. I think it's a small, in an overall national level, the amount that it would take to pay for physician education, like other countries do, Sweden, other
Yeah,
would be a small amount in the total budget, and would make such a difference in who goes into medicine.
but wouldn't this change the whole outlook if we had free medical school and nursing school for our healthcare workers?
Yes, I think that's an excellent idea. Another thing that's not covered in the public option, obviously.
Cynthia?
Okay, so a couple things. One, I want to mention that my husband is a radiologist, and he has been pro-universal healthcare for probably decades. So, and he's still working full time.
Michael.
Yeah, good for Michael. So, and then to address just the last thing you said, my daughter-in-law is a physician with, I mean, at the end, it was, I think, $300,000 in loans to pay off. And there is a program, and of course, these things keep changing. She works, I'm in Los Angeles, and she works for the county. She's a psychiatrist. And if she, after 10 years, there would be loan forgiveness. And of course, I remember during this last administration, they talked about like doing away with that or something. I don't know what the status is, but they're still hoping that there'll be loan forgiveness. But I mean, that was huge. And then the other thing I wonder is, I know that our legislatures in Washington, as well as the states, it's very hard to get this passed. And I also know about gerrymandering and who our representatives are. And what I want to know is, I guess, in particular in the state of Oregon, where you are, and maybe you talked about this earlier, is there a figure on the percentage of people in the state who would really like to have universal health care, even if the government doesn't pass it?
Yeah, there is.
Go ahead, Karen. Go ahead.
Well, that's a good question. Warren George, who is a retired business person in the Willamette Valley here, paid for a survey to be taken 2 years ago now, called the Elway study. That's the company that he engaged out of Seattle, which is a well-known company for doing surveys. And they did a statistically relevant survey. got equal numbers of Democrats and Republicans. And they found in Oregon that over 60% of the people, even when were told that income taxes would be doubled to pay for universal health care, were in favor of it. So there is a very healthy number of people who are not only supporters of it, but understand that it does have to be paid for one way or another. If you're not paying premiums, it's going to have to be paid for, like we pay for Medicare through, our own contributions and tax money. So that was very encouraging to see.
Okay, that's good.
Kathy.
Well, first of all, I want to say you both gave pretty compelling facts and figures for your points of view. And even with what you just said, Karen, about 60% of Oregonians being in favor of this one way or another, and all of the information that you both gave, it leads me to believe that the obstacles to actually having something with, whether it's public option or universal health care, have nothing to do with facts. So, it's like it's some kind of cultural phenomenon or something. So do you think that's the case? I mean, or do we just need to make the facts more well known, or what do you think?
Personally, I think there's a lot of that cultural, where your mindset is, that we have to work on, that is not impacted by the facts, and I don't have the answer of how to do it. We just have to keep working on it and having discussions and, trying to bring people. It's, in a way, it's like the reaction has been to COVID, where now as we're going along, the news today was reporting, well, the fewer and fewer people, or more people are willing to get the vaccine than there were earlier. They've seen it operate. They're less fearful. They're willing to get vaccinated. Maybe this issue is like that. I don't know. Mike, you've been in this arena for many more years than I have.
Yeah, we've learned a lot from Rush Limbaugh. He is very good at speaking right to the amygdala, and we can do the same thing. If you listen to him, you'll notice that he will say, that X, Y, Z, and it gets right in there and says, yeah, I do know that. And so if we can talk about this in a way that isn't wonkish and doesn't use statistics, but says, this plan is yours, you're in control, you control who you elect. This plan does not waste your money. You live longer and healthier. Instead of Elizabeth Warren answered the questions by going into a litany of how her program would work, a litany of facts, and she got blasted, and probably rightly so. She should take a lesson from Rush Limbaugh, and we all should.
Well, we told you this would be about an hour tonight, and we're at an hour and 15 minutes. So we probably should wrap things up here a little bit. So I'll give you another chance. Is there anyone who has a final comment? David.
Yeah, I can't. A public option plan would be based on a gold, or was it silver and gold, or gold and platinum, whatever. The sad truth is that the only plan that working people who are living paycheck to paycheck can afford is the bronze plan. I have heard rumors of a pewter plan coming, but we'll have to forget that one. But it's a sad truth that the only plan that too many people can afford to buy is the one that they cannot afford to use. If you are faced with a $5,000, $8,000 deductible, and you've got this kind of ache in your right upper quadrant, but it's going to cost you $200 to see the doctor. He's going to want some imaging. He's going to want some labs. It's going to run you $400. And as we know, 47% of families in this country cannot afford to write a check for $400 at any given moment. So the plan that people can most afford to buy is the one that they cannot afford to use. I'm terribly concerned that the public option will become a dumping ground by the insurance companies for the high risk, which will bump up the cost of that particular plan, and it will become a bust. And people will be telling us, see, the government can't do it right again. That's my concern.
Please voice it to the legislature on Thursday. The meeting starts at 3:15. House Bill 2010 is supposed to come up for hearing and work session at about 5:45. You can make your comments in writing by emailing to the committee, or you can register to do oral testimony. So encourage you all to consider what we've said, but form your own opinion and keep trying to become more educated about all of this.
Oh, I was just gonna say thanks for a really informative session. This was really helpful, and I feel like I've been learning, but I learned quite a bit more.
I'd kind of like to know, Mike, if you can take your screen down so we can all see, everybody. How many of you feel that a public option would be something worth pursuing that the legislature should pass?
Yes.
Yes, yeah. Okay. And how many of you think it would be a roadblock to single payer? Okay, interesting. Well, it's been a really interesting evening. I've enjoyed hearing what people have to say. Okay, I see two hands, Carol and then Shelley.
For people who are not on Mid-Valley Healthcare's mailing list, if you go to our website, Mid-Valley Healthcare Advocates initials.org, you can put your name down and you will get lots of good information on the web, on the newsletter, and you will get the agendas for the monthly meetings, which is the fourth Monday. And since Karen's been chair, there's always been a really interesting educational component to those Monday meetings.
Yes, just to follow up, Shelley, the next meeting in April, the fourth Monday of the month, April 26th, Henry Broska will be speaking on the Canadian healthcare system and how they manage their finances. He's from Canada. He's a medical researcher, very good speaker. And so we invite you to attend.
Yeah, and he's also going to talk about steps that can be taken legislatively to move us towards single payer, which I think is a real pragmatic thought we need to start exploring more than we have. They're working on it, but I think having the perspective of a Canadian who understands the Canadian system is something the task force has not been looking at, and we need to, because it's worked. So you're all welcome, whether you're whatever state you're in, you're welcome to join the meetings. So I guess it's time to say thanks to everybody for joining us tonight. It's been really, really wonderful to share thoughts with all of you. So thank you, and I hope that you'll join Mid-Valley and come to some of our meetings. It'd be great.